Okay, y'all, you know what? Let's go for it. It is 6:11 right after class. All right, so going over the lecture here. So as we have covered, dialectical behavioral therapy was originally created for individuals with suicidal and parasuicidal behaviors. For any of you who may be unfamiliar with that term, parasuicidal is self-injurious behaviors. So it's like on the verge of suicidal, kind of suicidal. So Marsha Linehan developed a biosocial theory of like why individuals, or what are the contributing factors for individuals who do respond in the emotional and expressively emotional ways that individuals who have characteristics of borderline personality disorder do. And as Sarah and Yasemin shared, this is now an approach that is applicable to not only individuals who have been diagnosed with borderline personality disorder, because again, much of the conceptualization of borderline personality disorder, like kind of critics of this diagnosis say, hey, wait, these are some trauma responses. And I don't think we should really pathologize that, especially given what Dr. Linehan was saying about, there really is a stigma within the mental health community of like, oh shit, I got another borderline. It's just very pejorative. It's a very, very stigmatized diagnosis. And for a field that is supposed to be quite inclusive and embracing and accepting and holding of space, there's very little tolerance in many ways for individuals who have characteristics of borderline personality disorder. So again, I encourage all of you to really like check in with yourself of, how might I have some biases, or how might I have some stereotypes around individuals who have characteristics like this, who have been diagnosed with borderline personality disorder, and potentially expanding your conceptualization to really be trauma informed. Because for me, how borderline personality disorder is outlined and described in the DSM-5, in the DSM-5 text revised that didn't change at all in terms of borderline, that it's just not really, it's not really factoring in some lived experiences of the individual that are quite self-protective. So Marsha Linehan. As we discussed, she conceptualized this, so biosocial, the biological and the environment. So she conceptualizes individuals with BPD as having been born with some kind of biological markers or some biological emotional vulnerability, which basically means that there's some inherent difficulty in regulating emotion. So if you're going to go kind of nature nurture argument here, we don't know. And as she said, there isn't necessarily a ton of research to support like how much, nature has to do with this, but it's kind of like a perfect storm a bit in having difficulty regulating emotion and then growing up in an invalidating environment. So this is when you are it's being communicated to you that your responses to situations are incorrect, they're faulty, they're inappropriate, or globally invalid. So you can see here chronically and pervasively communicated that how you are responding to this situation is wrong. So you can see how that if you're told that enough, how you're like, oh shit, I guess I believe this. So there are, of course, reciprocal influences between the biological vulnerability. So again, that inherent kind of difficulty in regulating emotion, and that environment that's invalidating. So these come together to create some dysfunction within the emotional regulation system. So according to this theory, how does something like borderline personality or having characteristics of borderline personality disorder develop? So again, these growing up in an invalidating environment, so taking into account like social learning theory, that the individual becomes intolerant of their own emotions. And so they try to punish themselves for it. Again, I am so faulty for wanting this. They suppress it, and you can only suppress for so long, as we know, before it's kind of like trying to put a cap on, or like a cover on a pot of boiling water. It's going to overflow at some point. They judge their own emotions. Again, they've internalized the process that has been shown to them, modeled to them. And just as we saw in the video, even when an emotional response is very reasonable, it is very normal, it is, you know, a common experience or a common response for humans, that they would judge that of themselves. And then they have low levels of emotional support in the home, in their environment, as well as high levels of what is called an EE in the research of expressed emotion. So the emotion that they do receive from individuals who are likely caregivers, you know, they are attachment figures in some way, they're influential or close to the individual in some way. They're met with criticism, hostility, and overly emotionally involved. So this could be something like, you know, what we term helicopter parents, just what we would term in other theories as diffuse boundaries, enmeshed boundaries. Those would be the types of emotional responses or expressed emotions toward the individual. It could be something like, you know, not taking responsibility for their own emotions. So, I mean, I don't know if any of you have ever experienced this, but you have somebody who says, look what you made me do. So it's like, it's almost as if the individual is simultaneously being told, you have no control in areas where they probably do, and then you have a bunch of control in areas that they don't. Like, you can't control other people's emotions, but for somebody to say, look what you made me do, it's so manipulative. But I know that people don't really see it that way when they're doing it. Maybe they do, I don't know. But just, you know, those would be some examples of kind of differing messages that would equally result in an invalidation of their own emotional experience. So feeling invalidated by others. So again, that's going to that emotional vulnerability, like biologically emotional vulnerability. And again, you know, you can lean as much as you want into either part of this. I would argue, by virtue of being a marriage and family therapist, that the environment has most of the influence here. And then they still influence others via their extreme behavior. So again, that's what I was talking about with that bidirectional, where they are very affected by their environment, you know, again, in that internalization process, in that emotional regulation process that is poor, but they also, by virtue of how they are coping, which is usually disproportionate, very extreme ways of coping with that emotional distress, that they influence the environment. So they get people to come to them to soothe them, they get ambulances called, they get taken to the hospital, you know, action happens when they engage in these self-injurious behaviors, or parasuicidal behaviors. And so that's a way of trying to soothe, but it's in the long term, very maladaptive. So quite adaptive, quite effective. Well, not adaptive, it's quite effective in the moment, but over time becomes ineffective and maladaptive. So through self-injury, through suicidality, they get help for the emotions that they are overwhelmed by. So it's the behavior is reinforced by the response that they likely want. So it's either a way to bring people to them or a way to get people to back off. So if I get really big and aggressive, you'll stop asking me to do something I don't want to do, or you'll quit asking me about, you know, something I'm uncomfortable talking about, or I don't want to talk about. So an assumption of dialectical behavioral therapy is that that kind of CBT process, right? The overlap, the interwoven nature of emotions, cognitions, and behaviors are attributed in a transactional pattern. So again, the combination of an emotionally vulnerable individual, so they have high emotional sensitivity, high emotional reactivity, and they're quite slow to return to baseline emotional state. So once they become escalated, they stay there for quite a while, and it's very difficult to move down back to, something that allows an individual to be more present or more communicative, articulate about what's going on with them. And then that invalidating environment. So again, one in which individuals' expression of their private experiences. So I have a perception of what's going on. I'm having an experience. I'm sharing it with you, and that gets rejected or treated as though it's wrong, maybe condemned, maybe they're shamed, and that it's having, this is so embarrassing. You are crying when we're at the grocery store or something like that. So punishment for emotional displays. You're crying. Go to your room. That kind of stuff. Intermittent reinforcement for it, and then. So it's like sometimes they get help. Sometimes it's just like very inconsistent. So, or potentially an oversimplification. You just need to suck it up. That only happened because this thing. So again, it harkens back to a lot of what we talked about in our class of the linear way that we conceptualize issues. This happened, so this was a result, and it's never that simple. So some of the fundamentals, DBT is helping individuals who have emotional vulnerability and a difficult time modulating or regulating their strong emotions. So again, vulnerability is conceptualized in this approach as a high sensitivity to emotional stimuli. So again, it might be like feeling just very affected by maybe something that didn't go as planned, maybe somebody else's response. So it is a really like a leaning into that emotional piece when we talk about the reasonable, wise, and emotional mind, really leaning into that emotional mind. And then, so you're sensitive to it, and then you respond very big to it again. Likely this has happened over time where you responded in a way that was probably pretty normative for like the human species. And then because you didn't get what you needed, you ramped it up. And as Dr. Linehan was talking about, with more invalidation becomes a bigger response, which begets a bigger invalidation. So it's a pretty kind of perpetual spiraling cycle. And then again, a slow return to that emotional baseline after arousal. So in order to emotionally modulate or to emotionally regulate, this is the ability to inhibit inappropriate behavior. So again, these are culturally bound, these are socially bound. These can also be aligned with personal morals and values. So it's usually that they're incongruent with values. Or kind of like, again, these kind of societal norms, which as we know can be inherently oppressive, but we do kind of have a way of order that we have deemed appropriate or inappropriate as a society, or we've had no choice but to align with it, right? So that is either, so if your emotional response is to completely shut down, then the hope would be that you would learn to kind of re-engage with yourself and be able to attend to or connect to whatever your emotional experience is. And in terms of if you're very, what we would deem kind of explosive, very expressive, in a way that is, again, deemed disproportionate to the situation, then you would want to bring yourself down so you can in the same fashion, connect to your emotional experience, have some insight around that. Organize yourself for coordinating action in service of an external goal. So again, it's important to understand, just like the exercise that Sarah and Yasemin did today of, okay, so you had an emotional response. What do you think was the function of that? Like, what was your goal in expressing it in the way that you did? That's important in terms of building insight and slowing down the process so that it's not so automatic. As I've talked about before in class, a lot of what we do in therapy is slowing people down and helping them become more aware of and in tune with their emotional process. So self-soothe through physiological arousal. So, being aware also of how your body is responding when you are in distress, when you are aroused, things like sweaty palms, feeling your heart rate ringing in your ears, sweaty brow, things like that. Knowing some of those cues, so that because those are usually get some physiological cues there before you start to really ramp up. So that could be an intervention point of, oh, here it comes. I'm going to engage in some of my self-soothing behaviors, my emotional regulation skills, so that I can not amp, or that I can, if I do start to go there, come back down closer to baseline. And then again, as Dr. Linehan was talking about, of these self-injurious behaviors, or the contemplation of these focuses our attention, which consequently helps regulate our emotion because our attention is focused somewhere else. So here, what you're wanting to do is focus that attention in the presence of those strong emotions, because the focusing of this is in response to, or in a reaction to, these strong emotions. But the focus isn't on the emotion, it's on, how do I escape? How do I get out of this? How do I run away? How do I disappear? How do I, stop feeling so terrible? But there's not really the recognition of what is exactly going on. Again, just like what Sarah and Yasemin presented to us of, there are people who are quite able to identify emotions, and others that really struggle with that. You will find that with your clients that, they primarily, almost exclusively, identify secondary emotions, or they say overwhelmed, numb, so these ones that are, there's something else there, but they're not quite able to peel apart what all contributes to that overall emotion, or they have a very small emotional vocabulary. So in DBT, 4 areas are emphasized: the acceptance and validation of behavior as it is in the moment. Again, this is the start of like building that rapport, building that relationship with the client, of accepting who they are and what they're bringing to you, which starts with also accepting yourself. So there's, the beauty in what we do is that we are forced to grow. We are forced as humans to evolve within this field, because what we are, or what we bring in terms of baggage and stuff like that into therapy, inevitably affects it. So if you are self-critical, if you are pretty dismissive of your own emotional experience, it'll be very difficult for you to hold space for another person. So that acceptance of the client, acceptance of self, and the validation of that client's behavior. So again, remember that validation doesn't equal condoning it or encouraging it, but is also reorienting that person to the possibility that their emotions are valid. Like, that is very novel for some people. We say it all the time in our field that, all emotions are valid. And sometimes they are a little off, by virtue of a little bit of a skewed perception, that exactly like what we saw in the tape of her assuming that he was mad at her, he was going to fire her, and that amped up her emotions. So her emotional response was predicated on something that wasn't true. It wasn't what was actually happening. So that's why he reoriented her to him and said, look at me, because what we do when we're feeling ashamed is we tend to go, it's called brain spotting, where we like look at a place where, so if you guys ever notice me when I'm like thinking, it's always up and to the left, or sometimes down and to the right. But those are my like brain spots, my areas. And those are also where I go when I'm feeling really embarrassed or shamed. But it tends to be that we, divert our attention or divert our eye contact because we're just steeping and we don't want to be seen. Or maybe we really do, but we're really feeling super vulnerable. So anyway, that kind of stuff. Treating therapy interfering behaviors, TIBs, otherwise known as, for both client and therapist. I will talk more in depth about what treatment interfering behaviors are. and the assumption that the therapeutic relation is essential to the treatment. So again, thinking of common factors, DBT is inherently interpersonal. So our biggest tool in that room when we're conducting individual sessions or family sessions is ourselves. We're the biggest tool. And the relationship that we build, that validation that we build with or show, express to the client is paramount. And then again, that dialectical process of accepting the client as they are, while also offering change. But it's not just what Dr. Linehan was saying. It's not acceptance to change, like what she was describing in terms of psychology. It is a radical acceptance of this is where they're at, while also recognizing they're in therapy, probably because something needs to change. But sometimes that change can happen when there's acceptance expressed and when there's self-acceptance. So that's the dialectical piece of the simultaneous existence of two of these things that seem to be very opposite of one another. Some of the functions of DBT is to enhance behavioral capabilities as evidenced by its roots in CBT, improves one's motivation to change. So by really imparting the message that, you know, you have agency over your emotional responses, you have agency over how you think about different situations, and that can have a consequence inevitably on how you respond to that. You have agency over how you respond, what you do, those behaviors. So you want to modify inhibition. So again, this is when, you know, I just go off the rails. I am completely inhibited to just do whatever. So that also, that could be to complete suicide. So you want to modify those and then reinforce any contingencies. So contingency management is a portion of DBT. I'll be honest, I don't love contingency management because to me, it's not really sustainable, but I can see how it would be useful in building a new skill. So it assures that new capabilities do generalize to the natural environment. So this is essentially talking about how efficacy can lead to effectiveness. So, you know, when you are in a natural environment, such as your home, such as your workplace, such as school, that the skills that you build in group or in individual therapy, they're not just effective there, that you can utilize these when you are interacting with people who are not your therapist or who are not fellow members of group therapy. So it structures the treatment environment in the ways essential to support client and therapist capabilities. So because this is so interpersonally focused, again, this is something where the therapist has to be really aware of what kind of stuff is brought up for them. So I know for me, I will share a story of a time where I really misstepped with an individual, an adolescent, who definitely, I don't know that she had been diagnosed with borderline personality disorder, but she definitely had characteristics. And so when I was in my master's internship, right where y'all are about to be, I worked in a partial hospitalization program for adolescents ages 12 to 17. There also was an inpatient unit, but this particular patient, because I was in a hospital, we called them patients, was in the partial program. So she was really, I had only one patient at a time, very invested, you know, very like eager beaver, intern wanting to save the world, help the world. I probably had, you know, some skewed views of what the purpose of what we do is. So she was in group. So we kind of had almost like, they weren't cohorts, but we had groups of kids. So they would be in our program for about 3 to 5 days at a time. So, you know, the first week of April, we might have a dozen kids, and the second week of April, we might have a dozen new adolescents. So the energy and the dynamics of our groups really varied depending upon who was in it and, what kind of stuff they were struggling with. So with the partial program, these were adolescents who had, just attempted suicide, who are engaging in self-harming behaviors, who had a violent outburst, who had a psychotic break. So these are we were kind of almost like not necessarily a triage, but we were like the crisis intervention step before we referred out to outpatient services. So we were, dealing with very short-term patients, but who were in a very active crisis. So I had my patient definitely had characteristics of borderline personality disorder. I'd had her, I think she ended up being in our program for 2 weeks or something like that. So by the end of her, maybe this was like midway. I think this was about midway through her stay. She was really acting up in my opinion, or at least in my perspective at the time, because I wasn't trauma informed, I'll be honest about that. She was in group with another adolescent, a female adolescent, where they both displayed characteristics of BPD. And so again, because I think I had internalized some of that stigma of like, oh crap, here we go, multiple individuals with BPD, great. Because what can happen is there can be almost like an escalating, like they can kind of amp each other up. So I had, again, that stigma that was internalized. So I probably lacked some patience and stuff like that. So we were in group. I think we were doing some kind of psychoeducation group, and she was being quite loud and disruptive. And again, I'm this kind of, insecure intern, really worried about doing well and doing things perfect and all of the stuff that I know that all of you contend with, because man, it's very humbling. Anyway, so in group, she goes, "You're my friend, right, Sarah?" And I looked at her and I go, "I am not your friend, I'm your therapist." Just like that. So if you can think of how invalidating that was and how triggered I must have been as her therapist. So she immediately shut down. We had individual therapy every day. And I knew immediately that I had messed up. I had become dysregulated. I had snapped at her. It's like I was worried that all of the work we had done building rapport up to that point was gone. So that was my first therapeutic alliance rupture. So I went to one of my colleagues, one of my mentors in the program, and I was like, "I think I messed up. Here's what happened." And I gave her a play-by-play, and she goes, "Yeah, it wasn't great." She said, "You've got to repair this." So ultimately what she said, which I still agree with today, because I think we've talked about this in class before, about that boundary of being called a friend. And it's like scary. Can I be a friend to my therapist or to my client? And what she said to me was, "I think you need to go to her and say, I'm really sorry for what I said. That was unnecessary. That was rude. I really apologize." And without expecting like forgiveness or anything like that, because when you apologize as a therapist, it doesn't have to be an exchange. And as we know, when you apologize, you can't really expect forgiveness. So she said, "You need to apologize. And then here's what you can say. You can say, if you are talking about a friend who really cares deeply about you, who wants you to do well, who is here to support you, who is here to talk to you, absolutely, I am that friend. If you're thinking about a friend who like goes to the movies with you or goes out to eat with you, I can't be that kind of friend." So she kind of differentiated and created that boundary in a way that hopefully was accessible to the patient. And so I did just that. And I think that we moved forward from it. But I mean, I really messed up. And so I wasn't aware of my own stuff and how I was really building an intolerance and an impatience with her. So it was a learning experience for me. So hopefully that helps maybe normalize some of the missteps that will inevitably happen with all of you. And then DBT also helps us in our capability and our motivation to treat clients effectively. So again, this is really about being trauma informed, being patient, really, really embodying validation, and embodying emotional regulation too. So we're modeling for the clients what we're asking them to do. So as I said, dialectics. So this refers to opposing forces that create a whole or a synthesis. So if you remember the, thesis of that idea, the antithesis, the opposite of that, and how they can come together, and the goal is synthesis. So it's essentially like finding the balance or finding the middle. That's a part of that. So in dialectics, it's, oh my gosh, I am in this emotion. I need to escape. I need to do something pretty big. And it's okay, you can have this emotion, and then we're going to create like, what is an alternative option for you to attend to this or to express this. So I don't know if all of you caught it in the video. The skill of the week with Alice was called alternative rebellion. So, when people feel like they have been wronged or something's been unjust or something like that, they may act in a way that is maybe incongruent with values or disproportionate to the situation. Again, that's subjective, as we know. But her alternative rebellion, so instead of, because what she would do is she would take out her emotions on herself, so self-injurious, and she would restrict her eating. So instead of doing that, what she did was she peed in the shower. So it was still a way of kind of expressing herself in a way that wasn't harmful to her and wouldn't have long-term negative effects on her interpersonal relationships. So that was an example of a synthesis. So opposites can be integrated to form a closer approximation to the truth. So again, if you're very, very emotional, likely your perception has been skewed in some way, probably informed by your big emotional response, or your emotional reaction, I should say. And again, if you are very logical, you are likely disconnected from your experience. So this balance is, like I said, accepting the client exactly as they are within the context of helping them change. So again, it's not an acceptance toward change, it's an acceptance and being in a context of helping them change, because again, they're in therapy. So likely there's something that needs to change. So just some examples of opposing forces that are all around us. The sun and the moon are opposing forces. The seasons are opposing forces. So just giving you some, outside therapy examples of dialectics. So the philosophy of this approach, as I was saying, reality consists of opposing polar forces that are in tension. So that thesis and antithesis of I am having these emotions and they are wrong. Those are forces. So it's, how can I bring some self-validation into this while also responding in a way that's adaptive. So an example of this, the push to apply change-oriented treatment strategies creates tension by increasing the patient's desire, the client's desire to be accepted rather than change. So like we said, if you push that change on somebody, they may dig their heels in and just ask for, like, I don't want to change, I want to be just as I am. But it's interesting what Dr. Linehan has experienced is that, like, the more acceptance that you show, the more validation that you express and demonstrate, like, the more amenable an individual is to changing. As it builds self-confidence, it builds a connection to their own experience. And the dialectical philosophy also poses that each opposing force is incomplete on its own, and that these forces continually are balanced and synthesized, so that really one extreme can't really exist on its own, that the opposite has to be there. But the goal is to find that middle ground. So with that, focusing completely on change-oriented efforts was, as she learned, an incomplete strategy. That's why she added Zen to CBT. So it lacked the essential ingredients of acceptance, as she was talking about. On the other hand, focusing completely on acceptance also may be incomplete and ineffective, as multi-problematic suicidal patients require extensive changes in order to create lives that are worth living. So that's the balance, that's the dialectical balance. So here, just the process of being nothing and being. So it's a bi-directional process of becoming. So to occupy a space of nothing, which again, that's, lack of self-esteem, lack of sense of self. And then this being, there has to be a process of becoming, but with that dialect, this is one extreme and this is the other. So there's a balance here, and becoming is that. So it's like a leaning into self-growth and evolution, because we're never just where we are going to be. We're always on a journey of getting there, if that makes sense. Hopefully, if not, ask questions. So weighing and integrating contradictory facts or ideas with a view of resolving apparent contradictions. So it's understanding that contradictory facts usually exist. The fact that my feelings are invalid for these reasons, they're also valid for these reasons. So how do these simultaneously exist? And that is, some of that gentle challenging, that some of that irreverence of like, okay, tell me how these are both simultaneously existing, or how do you come to a middle place of this? How do you come to a place where the contradiction is either closer or resolved? So opposing internal forces in the state of continuous change. So these are the cores of the dialect. Accepting individuals as they are in the context of helping them change, and finding a middle path. So this is that thesis, antithesis, synthesis. Thesis, or I would say this is probably, well, it doesn't really matter. Thesis, antithesis, or antithesis, thesis, and this is that synthesis. So again, that middle path or balance in synthesizing these opposing experiences. So the goals, we want to help the client decrease dysfunctional responses to that experience, the emotional experience. So again, these dysfunctional responses allow escape, and we don't want the client to escape from that. We want them to acknowledge that, be present in it, and work through it, and tolerate it, have some distress tolerance, reinforcing the opposite action of, so again, if your response to distress is to contemplate or to attempt suicide, like what's the opposite of that? And then what is a potential middle path? So there's, sometimes the middle path is a little bit farther toward the opposite. But we're increasing the skills that I will talk about what they are. These are skills that Sarah and Yasemin already mentioned, several of them. Quality of life behavior, so interpersonal relationships, self-efficacy, hope, having a job, having a home. These are quality of life things. Building confidence within the client, and then building motivation to create a life worth living. So you don't, I'm wondering, Jocelyn, in what you were saying of, so they just have to accept their situation. That's not exactly it. They are building motivation to potentially change some circumstances. And I know sometimes it's, bigger, but there are potentially some things that are within their control, seeking resources. So if they have, for example, inconsistent housing, that would be part of our job there, and helping them with the quality of life of finding consistent housing, or at least temporary housing that's consistent, so they're not homeless at periods. If they don't consistently have access to food, where we would connect them with like food pantries, or just, organizations that offer meals and stuff like that. So that would be, I am worthy, so I'm going to be congruent with that, and help myself or utilize the help from others in creating a life that I actually can enjoy, because I'm not having such a good time right now. So what do we do as a therapist? So, this, Julie, is the question that you had brought up. So there's two different types of balance. So again, thinking of those dialects. So unwavering centeredness, where you believe in yourself, you believe in the client, and you're bought into the treatment. So remember, just like we were talking about with common factors, allegiance to the theory is really important. Having belief in the benefit and the outcomes of that, the potential outcomes of that approach is really important. Then having balancing that, so being pretty like centered in your belief, but also being compassionately flexible, the ability to take in relevant information about the client and modify your position accordingly. So it would be what we call matching in many ways of, matching posture or complementing posture. So including what we saw in the video of the ability to admit to, and the story I told you, hopefully this makes sense, admit to and repair to one's inevitable mistakes. So when he said, "You look terrible," and she goes, "Thanks," she was already feeling crappy. So then he quickly admitted, "I said that wrong. I apologize. Let me back up and try this again." And exactly what I did of, "I'm really sorry. That was insensitive. That was rude. Let me try again." And then what we were talking about with that warmth and irreverence is the nurturing style. So you're teaching, you're coaching, you're assisting, you're in this very supportive role while always encouraging. There's a cheerleader kind of posture position within this, but also benevolently, there we go, demanding. So you are, dragging out new behaviors in the client. You are doing repetition. You're potentially annoying the client, because in a way, this is showing, "I believe in you. Let's keep going. You got this. You can persevere." Recognizing the client's existing capacity to change. So, when we talk about scaffolding, not going beyond their capabilities, but not being so flex or lax, I guess I should say, that you're not pushing them in probably a way that they need. Because again, with those interpersonal things, what we tend to do, and I think we'll talk about this in future slides, is either be way too rigid or way too lax. So there's that balance there. Having clients do for themselves rather than doing it for them. So again, allowing clients to try shows that it can prove to themselves that they've got it. And it also shows, "I'm here as the therapist for you. I believe in your ability to try this, to do this, and I'll be here to support you if you need it." So that's, again, like what I said, those kind of not so tangible moments in terms of interventions or approaches, that it's like what is it meta communicating to the client? So some treatment strategies: a non-pejorative stance toward the individual and their families. So this where I pulled this article from was talking specifically about adolescents, but this approach applies regardless of age. So non-pejorative just really means like you're not blaming anybody. You're taking a pretty compassionate approach to recognizing that there's some contextual stuff. There's some dynamics, there's some relational stuff that's definitely informing this. No one is inherently flawed. No one is inherently to blame. Because I think particularly sometimes when we look through like a trauma-informed lens, we can get a little bit judgmental about parents and like, "Oh, so just so you know, BPD, one ingredient of this is an invalidating environment. Like, why didn't you validate them?" So you don't do that. It's an empathic view of the family behavioral pattern. So again, everything makes sense in context. It really does. The more that you're in this field and the more that you give yourself a chance to be patient and just really learn about people, get to know people, humans sincerely are trying their best. You have a non-blaming stance toward the parent. So again, even if this is an adult patient or an adult client, and you bring in their family of origin, or you talk about their family of origin, because it doesn't really help the client when you quote side with them and just kind of, so let's say the parents aren't present. If you were to just be like, yeah, your parents really suck, they were invalidating, that's not helping the client necessarily move forward or see where they contribute to that dynamic as well, or where they are contributing to their current distress or their current presenting problem. So sometimes we validate by kind of vilifying somebody else, and that can like maybe feel good in the moment, but largely that doesn't really in the long term help the client. So they have to have some ownership over their contribution as well. So remember, invalidating environment, but these behaviors are also meant to influence the environment as well. So it is a bidirectional, circular process. So DBT assumes that adolescents and families are both in pain. Imagine a parent consistently worrying about their kid killing themselves, always being worried about where they are they hurting themselves, or being a parent knowing that your child is really suffering. So again, parents can experience intense shame, feeling like they're failures as parents. So if you have a child who's potentially consistently attempting suicide, what does that say about how you've done as a parent, especially in society when I would argue that parenting is the most criticized job on the planet. Excessive fear for your child's safety, guilt about their participation in I've contributed to this dynamic crap. So some of the ways that you can do this is semantics. So using terms such as poorness of fit of temperaments, as opposed to just poor temperament, bad, faulty temperament, something like that. Labeling behaviors as invalidating versus the family being invalidating. So the behaviors are invalidating, the humans are not inherently invalidating. So this is what I typed in the chat about guilt equals I made a mistake. So that is the behaviors are invalidating versus shame as I am a mistake, or the family being inherently invalidating. Also, you can Bowen's everywhere. He's great. Using genograms to gain insight into some intergenerational transmission of invalidation. So again, that can help with some of that shame and guilt and self-blame of the parents of what have I done. It can also help the IP, usually again, the adult child or the adolescent who has been identified as the patient, to better understand some of the parenting behaviors that they experience, that they were the recipient of, seeding their parents and potentially probably some level of an invalidating environment as well. So greater acceptance among family members of, oh, okay, so given that this was modeled to you or provided to you from your parents, makes more sense that this is the only way you knew how to parent me. It can also create some frustration, but that's able to be processed of well, you knew what it was like to be invalidated. Why would you do the same thing to me? So it can go either way, but that's always rich. Those transgenerational or intergenerational transmission of those dynamics is always rich to process. So skills training. So core mindfulness is again able to focus on something. So you're focusing on the emotional experience versus the how do I escape from this experience. Distress tolerance, as we talked about. So when I am distressed, I'm in crisis and I'm just trying to survive. So as opposed to being in crisis and trying to survive, I'm trying to be more mindful and accept what's going on and accept that my emotions and my emotional response to this is valid. Emotional regulation, de-escalation. So these are things like grounding, connecting with a trusted other, tapping into a support system. Interpersonal effectiveness. So this is, learning people skills. How do you interact with people? What's appropriate? What will be more effective in getting what you need in the moment? So this is, can be really useful for individuals who become quite aggressive so they're feeling overwhelmed, stuck, backed into a corner. And what do people do when they are backed into corners? They usually start, metaphorically punching out their way out of it. So this is a way to be aware of that tendency to do that, but use your words as opposed to crying or threatening or running or screaming or something like that. So this is again, the dialect of acceptance and change. So the 4 components here of mindfulness. So being aware of the present moment without judgment. So that's a big piece. And what I was talking about in the chat of many times our emotional distress comes from the judgment of the initial emotion. I shouldn't be feeling this way. What a ridiculous emotion to be feeling. So it's like there's self-judgment on our initial response. So then we focus on the judgment, and that's how we escalate. So the acceptance is mindfulness, and that distress tolerance is under acceptance as well, of managing a crisis without worsening the situation, accepting reality as it is. So those are the pieces of acceptance, but they're complemented by elements of change, like emotional regulation. If you're regulating emotion in a different way, that's inherent change. So understanding and reducing vulnerability to emotion. So it's too much. I'm too exposed. I'm feeling too much. So you can hear all of the judgment in that. And then changing those emotions, which usually means altering the judgment of the initial emotion. So with some distress tolerance and accepting the situation or accepting the emotional experience, that can help with emotional regulation. And interpersonal effectiveness is those people skills of getting your needs met, maintaining relationships, increasing self-respect in relationships. So again, you're going to try a different tactic to get your needs met, because boiling over and becoming explosive and threatening and self-injurious, it can be effective, but like I said, long-term, pretty maladaptive. Doing that on a consistent basis is a great way to push people away. Whew. She is so much, too much for me. She's very triggering for me. I can't be around her. You don't want that. As relational beings, we never want that. And then also increasing that self-respect can be in learning to validate yourself, but that starts with the validation of the therapist. So we're really integral in that part, or in that process. So integrating mindfulness. So mindfulness is awareness plus acceptance of the current moment. So you're very present in it, and you're, again, accepting of the emotions and so the emotions that's helped by accepting likely most elements of the situation. If you are, you're not going to be like, I don't know, driving off of a bridge or something like that and being like, I'm just going to accept what's going on. It's not like that. It's not when your life is in danger. It's these, when it's reasonable to accept what's going on. Focusing on one thing in that moment without judgment. So usually that's the emotional response. The ability to have awareness of your sensory and cognitive experience. So again, this is mindfulness. An example of this is grounding, which is 5, 4, 3, 2, 1. 5 things you can see, 4 things you can hear, 3 things you can touch, 2 things you can smell, 1 thing you can taste. So you're engaging all 5 sensory, or all 5 senses. And then the ability to discern. So that differentiation, this is that reasonable self, emotional self, wise self, or mind, I'm sorry. The ability to discern emotions, verbal descriptions of events, appraisals or attributions, and judgments of the events, memories, perceptions of the events. So these are all separate things. So when we become very emotionally escalated, all of these become the same. So it is unpacking each piece of that. And again, with mindfulness, it's a slowing down, and it's becoming aware of all of these parts, all of these pieces of how we do make appraisals, what goes into making an appraisal, and separating each of those parts, being aware of each of them. So here's the graphic of the wise mind. So as you can see, in this Venn diagram, the reasonable mind is cool, rational, task focused. Also, the risk in going here is becoming emotionally detached. So you kind of lose a sense of yourself. You lose touch and attunement with your natural human experience of emotions. Emotions are never to be denied. They're never to be pushed aside, because we literally can't do that as humans. We can't vilify something that is very normative to our lived experience. So when you're in your reasonable mind, you are ruled by facts, reasons, logic, and pragmatics. The values and feelings are not important. So that's the problem here. Values and feelings not important. You can't stay there. And then again, on this kind of continuum, the emotional mind is hot, as you can see, opposite of cool, mood dependent, opposite of rational, emotion focused, opposite in some ways of task focused. So when you're in your emotional mind, so this is where individuals with BPD hang out. They're in their emotional mind a lot. You are ruled by your moods, feelings, and urges to do or say things. Facts, reason, and logic are not important. So as we know, these are inherently important. So when you hang out here, your attributions of situations are usually, your perceptions are usually a bit skewed. This interferes a lot with interpersonal relationships. So the goal is to employ your wise mind. So the wise mind is within each person. Again, if we liken this to Bowen's sense of differentiation, that's finding that middle ground, that balance between autonomy and connectedness. Going with IFS, this is engaging the self, capital S, self, the CEO, whatever. So you're seeing the value of both of these and accepting the existence of both of them without judgment. So this is bringing left brain and right brain together. I think left brain is reasonable or rational. I don't know. I think right brain is more emotional, creative, or something like that. I don't know. Feel free to make a comment or something on this. And then you're finding the wise mind is inherently that middle path, the integration of all of this. As you will find, that's a theme of many of the approaches that we're covering this semester. So practicing mindfulness, again, it's the process of observing. So just notice that was one of the suggestions that the therapist made in the role play of, just observing some self-judgment, just observing when it's happening, not judging self-judgment. It's here, it happened. Okay. It's kind of like, this is mindfulness is a big part of acceptance and commitment therapy. And in acceptance and commitment therapy, they talk about kind of like, observing the emotion as if it's just like floating by and being like, hey, okay, that's interesting, and just observing and letting it go. So you're describing it, you're putting it into words. Again, this is the insight-driven portion, becoming more connected to your experience. You're participating, you're present, you're being involved in what you are doing. You are an active participant. You're learning how to notice without reacting. This is the amping piece. I am where I experience something and then I'm reacting to that experience. That's what we're trying to mitigate here with mindfulness, distinguishing between thoughts and facts. Again, some postmodern approaches would say they're not different. Being non-judgmental. So again, these are just, they're not good or bad. You're not applying a value to them. Be one mindful, as Sarah was sharing, it's focusing on one thing, being very present in the moment, and being effective. So finding what works in the long term as well. Because as we said, the tactics that individuals with characteristics of BPD usually effective in the moment, but again, long-term, very detrimental. So working with families with DBT. So this is where, as therapists, we are susceptible to responding in the same way that families have. So there's some polarities, again, that those dialects within families. So they can be excessively lenient. super lax, or very authoritarian. So having too much of either of these is problematic. They normalize pathological behavior, and they can pathologize normative behavior. So these are, again, these mixed messages. I don't know what's right. I don't know what's real. Forcing autonomy while also fostering dependence. So again, just very confusing. Imagine a child raised in an environment where they're, left is right, up is down, purple is blue, just very confusing. So when working with families, you're trying to find the middle path. So these are some of the patterns that families tend to fall into. So you want to be authoritative. So again, permissive and authoritarian are kind of the two ends of the spectrum in terms of parenting style. The goal is authoritative, discipline, and decreasing excessive leniency. So we're not going authoritarian. We're not going super controlling, not allowing any autonomy with the child. But we also are not just letting them do whatever they want or whatever's convenient. Because as we know, parenting is a hard job and there's some effort that needs to be put into it. And then increasing the adolescent self-determination while decreasing authoritarian control of the parents. So with DBT, this was your question, Lawrence. It is usually weekly sessions, 50 minutes plus attendance of group therapy, which is usually either every week or every other week. These are specific to skill building. So they're more psychoeducation. There is some process, but the weekly sessions are more meant to process like what's been brought up in the group therapy and stuff like that. Typically require quite long commitments. DBT is by no means a short-term therapy, and homework is, so with that CBT being informed by CBT, that is where homework is an integral part of this process. So the weekly therapy is 50 to 60 minutes. You also are doing telephone coaching and some crisis management. That might not be the same person. So as the therapist, you would not necessarily be the person who is attending to the crises. That could be another, individual at the practice, or, a professional companion of some sort. And then, as I said, the skill training, these are groups of 5 to 10 individuals. They don't talk about self-injury or suicide attempt or behavior. There's focused on skills, very structured in the didactic format. And it is not a place to process. Like I said, that's done in the individual therapy. We watched this. Oops, did I miss something? Nope. Okay. So I'm going to show 2 different slides of stages of treatment. So the first stage is moving from being out of control of one's behavior to being in control. That's the goal of the first stage. The focus is on stabilizing the client and achieving behavioral control. So they've had this experience. How can we respond to this in a different way? Stage 2 is moving from being emotionally shut down to experiencing emotions fully. So the goal is to replace this quiet desperation. Again, you've been invalidated. You've been told that your emotions, your private experience is wrong. So it is tapping into that emotional experience, feeling it, and then being given validation, being modeled validation, and then giving that to yourself with non-traumatic emotional experiences. So one of the kind of quintessential characteristics of an individual with BPD, or has characteristics of that, is really making mountains out of molehills. These are non-traumatic events that trigger a traumatic response. So again, it's decreasing the disparity. So it's not this disproportionate response. Stage 3 is building an ordinary life, solving ordinary life problems. So one of the, like I said, the mountain out of molehill stuff is potentially these kind of minor inconveniences that are just overwhelming. The goal is to achieve ordinary happiness and unhappiness. So again, the highs and lows of an individual with characteristics of BPD, or who has, emotion regulation issues, substance use, things like that, they're huge. And the highs and lows, that's again normative to the human experience, but the goal is to make the highs a little less high and definitely the lows less low. So there's more of this more even experience. And reduce ongoing disorders and problems in living. So that can be, again, things like quality of life, which include interpersonal relationships. And then the final stage is moving from incompleteness to feeling a sense of completeness and connection. So a sense of internal completeness and connection to others. So being able to achieve joy. So the orientation of treatment is to first get action under control, the behavioral response, then to help the client feel better. So this is like crisis intervention. Okay, now let's focus on going from feeling like crap to at least feeling baseline, to resolve problems in living and residual disorders, and then to find joy and for some sense of even transcendence. So in Maslow's hierarchy of needs, the top has historically been self-actualization. But many people argue that a even higher order of that is self-transcendence, which really is, a feeling of connection to your fellow humans, feeling of oneness, of what would be considered like true self-acceptance. So if anyone's interested, you can do some reading on self-transcendence as a higher piece of Maslow's hierarchy, higher than self-actualization. So with families, these stages can look a little bit different. So pre-treatment, that's orientation and commitment, what Dr. Linehan was talking about, contracting, otherwise known as contracting, listening to and validating the family's experience and attempts to problem solve through reframing. That makes sense to me. When this happens, you do this thing, other people observe this and they respond in this way. So you're going very circular and transactional in how you are narrating what they are telling you and how you're responding to that. In this section, you are also, or in this stage, I guess, you are also psychoeducating about the biosocial theory of DBT. So again, biological and environment, and obviously this is including family therapy. The assessment of the potential roles. So is somebody going to be in the role of an informant? Are they a support? Can they be a coach? Who is the treatment recipient? Who are the contingency managers? Based on family strengths, needs, and willingness. So that the assessment is like, who can I put in what role, or who naturally occupies what role, given the information that I've gathered through this assessment. And then a commitment to specific roles within treatment, a time frame, and goals. So you're building your treatment plan in pre-treatment. That's the orientation and commitment stage. And then 2 additional stages to this. Stage 1 is safety, stabilization, and connection. So you are moving through any crisis. Again, if there is active crisis, like, active suicidality, something that's going to be a risk to someone's life, you attend to that first. You're not going to assess knowing that there's like active suicidality or active self-harm. Just like Dr. Linehan said, like that's the antithesis of therapy, is like being complicit in life, in ignoring in behaviors that someone may be engaging in that could cost them their life. That's literally the opposite of what we're supposed to do in therapy. So this is highly structured to establish safety. So when they're in session, there's specific guidelines in order to maintain safety. So this is where that contracting, contingency management comes in. And then when they're home, you're classifying parental authority rules and protective services if needed. So those additional professional resources, if they need it, and you are as a group, so that you're not just giving the family rules to abide by. They have consented, they have likely helped build those rules. So again, it's structure, predictability. These are all things that are very safety, encouraging, fostering things for particularly adolescents. And then brings some more sense of control for parents as well, Behavioral analysis, we talked about this last week, again, CBT. So in the question that you had asked at the beginning of class, Harley, are the interventions pretty CBT in nature? Yeah, with the emotional, more of an emotional focus than CBT, or this mindfulness lean with CBT. So behavioral analysis of the family interactions related to any targeted problem behavior. So again, like with Alice, if her family would have been there, it would have been focusing on her restrictive eating and her outbursts, I guess, for lack of a better term. Engagement about contingency management. So you're identifying the reinforcers. You want to reinforce desirable behaviors. You want to, whatever the opposite of reinforce is, undesirable behaviors. Understanding the principles of reinforcement. So you have extinction and punishment as a last resort. Part of extinction could be, continuously ignoring. So when like, that your child's life isn't really at risk, not giving attention to these behaviors that you no longer want, or that the adolescent no longer wants to be existing. And then punishment is not a preferred method within contingency management. Then skill enhancement, that acquisition and the generalization. So again, whatever you learn in therapy can be generalized to other settings like home, school, work, things like that. Then the second stage is emotional processing. So exposure and response prevention for these intense affective and relational triggers. So again, you're identifying them so that you're not responding to them in a way that is, in the long run, and quite frankly, in the short run, in many ways, destructive. And then as a family, I think it's a fair assumption honestly, in the human plight, I think it's fair to assume some level of trauma. So processing any shared traumas that the family has experienced, like suicide attempts, any hospitalizations, abuse that maybe has occurred in that nuclear family, in that family of origin, or in that nuclear family, or in their respective families of origin, any separations, divorces, abandonment, betrayal, things like that, any sort of harmful treatments. Again, this could be discrimination, some experience of marginalization on a larger scale. It could also be harmful past treatments in mental health. We're not immune as a field to that. And then lost time, maybe lost time together because of separation, with like a hospitalization or a placement or something like that. And any sort of developmental phases. So again, this could be family development, some family life cycle stuff, or individual life cycle stuff. So change. Targets of treatment for the individual is, as Dr. Linehan said, target first any life-threatening or parasuicidal behaviors. If the person isn't alive, they can't participate in therapy. So you got to ensure that they will live, ensure their safety. That is also, as we know, your ethical commitment to being in this field. So second is to target those treatment interfering behaviors, those TIBs, as I mentioned earlier. So these are things like missing session, last minute cancellation, not being collaborative. So this is when the client may be verbally attacking the therapist, criticizing the therapist while the therapist is attempting to help. So these are things that that can't be existing in treatment for it to be effective. Non-compliance, so failing to bring homework. Again, this is quite structured. So there is an expectation with that. Refusing to complete their journal or their diary cards, refusing to get rid of any sort of lethal means that they may have in their possession, just in case. So these are things that can't be existing. Phoning at unreasonable hours. So again, you're going to, with your client, essentially agree upon reasonable hours. And if they call outside of that, you have to process that in session. And then something that can push the therapist limits. So, let's say that, for example, as a therapist, you self-disclose something, and then that is, used against you later. You would share with your client how them doing that affects you. And you would probably validate, some sort of emotional state that they may be in, to say, you're feeling a certain way now, and it's not okay to do what you did. But that doesn't, just because you are correcting the response or the reaction to that internal state, doesn't mean that internal state wasn't valid. It means that the behavior that they chose to engage in was harmful. So the third is to target behaviors that interfere with quality of life. So these are things like depression, relationship difficulties, substance use, homelessness. So you want to decrease these behaviors, things like substance use, self-harming behaviors, increase in behavioral skills. So again, this is some of the interventions, right? These are some of the skills that you would be, so maybe another way to answer your question, Harley, that you posed in class was, so in individual therapy, it's a lot of reinforcement of the skills that are learned in group. And the primary intervention in that individual therapy is validation. But the skill building is primarily what's going on in the group. So you're complementing that. So as you're learning mindfulness, because in individual, you would talk about, like, when have you applied this? How was that for you? That kind of stuff. Distress tolerance, interpersonal effectiveness, which we talked about, self-management, emotional management, and emotional regulation. And last but not least, talking about the 6 levels of validation. So these aren't necessarily like chronological, they don't necessarily build on one another, but these are all the different like approaches to validation that you would be using when you are interacting with your client and with your client's family, whatever system you're interacting with. So the level 1 validation is listening to the family in an unbiased manner without attempting to change anything in the moment. So again, it's this acceptance. You are expressing and demonstrating an acceptance. The second level is where you are accurately reflecting thoughts, feelings, and assumptions of the parents. This fosters treatment alliance with the parents. So again, this is one of those approaches that, like many other systemic approaches, asks who's got the power, who's got the influence. We got to build an alliance with that. Like, who's in charge of kind of bringing the family into this? We got to make sure that we've got buy-in with that person. So the third level is you are mind reading or articulating individuals' unspoken thoughts and feelings. So this is, again, I'm connected with you. I see you. You are valid. This makes sense, that kind of stuff. Level 4 is understanding of historical antecedents of the behavior. So this is where you're doing some genogram. You are talking about problematic patterns and understanding what precipitates that. Again, like I said, you're recognizing transgenerational patterns of invalidation, and you're looking to understand the current behaviors in light of that, which, again, history makes things make a lot of sense as well. The fifth level is you're confirming thoughts, feelings, and behaviors based on the current context. So you're reinforcing good judgments, for example, on the parent's behalf. So an example of this is, you knew you needed help and you reached out. Like, that's awesome. Because again, just think of the confidence of the parents too. So this is that non-pejorative stance. This is shit scary, and you probably feel like you've really messed up and you've really failed as a parent. Let me identify places where you have exhibited good judgment. Then the sixth level of validation is that interpersonal piece. You gotta be genuine, especially with adolescents. To me, adolescents are some of the best sniffer outers when somebody's being disingenuous, but you're really you're sharing with them as a fellow human in the room. So you're speaking authentically to the family about their experience, like how you would speak to your own family members. You're reinforcing this egalitarian stance. So this is collaborative. I have feelings in this too. I have impressions of this too. So that's where the self-validation is really important in this approach. And tapping into your humanness and understanding kind of some of your triggers too. So you're reinforcing the egalitarian stance by giving feedback or direct feedback with recommendations, but also asking for feedback from the family. So it's this kind of bi-directional process. All right, y'all, and trying to stop the share here. That's it.